Great. Well, morning, everyone. We're going to go ahead and get started. Thanks for being with us early on a Monday. Today's topic is on oral oncolytic management, as well as just a brief introduction to our specialty medication service and prior authorization. This topic is probably a little bit more operational versus maybe some of the more kind of clinically focused pharmacology topics, but kind of over the years with the course felt like it was, I guess the feedback we got was it was valuable to include just because it's very important to prescribing chemotherapy at UW Health. So this session was meant to be a bit more interactive with some of the policies and such. We've done this virtually, of course, the last couple of years. Admittedly, it's been a little bit more challenging on a WebEx platform versus being together in the same room, but by all means, if you have questions as we go throughout or inputs for those of you that are already familiar with these points, feel free to interject and we can discuss further. So for those of you I haven't met, my name is Jason Bergsbaken. I'm a pharmacy coordinator within the service line. I do serve as Secretary of Chemotherapy Council, which is our oncology P&T committee. I think Mary reviewed briefly some of the topics about Chemo Council. I work kind of sporadically throughout the clinic as well as inpatient. So if I haven't met, I look forward to working with you. This is what we're going to cover today. Again, our focus is really on oral oncolytic management and kind of everything that goes into that from a process perspective. And then at the end, we'll briefly touch on our specialty service as well as prior authorization, given that does impact our workflows regarding oral oncolytics and other chemotherapies. So just some background. I know many of you are familiar with this, but regarding the importance of oral oncolytic management, as we're all aware, we've really seen a pivotal change in cancer care in terms of how oral oncolytics are incorporated into many of our treatment paradigms. Based on our definition at UW Health, we now have over 70 products which are defined as oral oncolytic chemotherapy versus 20 years ago, I'd say we were maybe around 30. So it's definitely an area that has grown rapidly. As we all know, there are challenges with managing these. While there can be benefits in terms of patient convenience and doing some of these at home, there still are barriers or challenges which may include some complex dosing regimens. Adverse effects are still prevalent, and we kind of have this change where we're relying more on the patient to report us those things versus maybe laying eyes on patients when they present for an in-clinic type of therapy. So because of those challenges, it's really important that we as a system have processes in place to ensure that we're starting these patients on therapies safely, as well as how we're kind of monitoring them as they receive them. So I thought it'd be worthwhile just to share a little bit of our story here at UW Health and kind of how our oral oncolytic management has kind of evolved over the last probably about 10 years. I think part of this is kind of in parallel to some of the changes, like I had mentioned, in regards to the prevalence in which we were seeing these agents being prescribed, as well as some changes in kind of what's available kind of nationally in terms of best practice for how we should be managing these agents. But I would say, over 10 years ago, we had at that time just really a lot of reports, and this is prior to some of the policies we'll discuss today, but of kind of misadventures as it relates to oral chemotherapy. So at that time, we were, we didn't have a process that was defined with the use of treatment plans. We were having a lot of handwritten prescriptions that were being sent, which circumvented a lot of our electronic kind of safety mechanisms. We had reports of local pharmacies that were receiving these agents and kind of the disconnect in dosing or monitoring, patients not understanding how to take the medicines, and then ultimately kind of a higher prevalence of patients who are being hospitalized for adverse events related to the oral medication. So at that time, due to some kind of internal quality assurance work, we had really shown a very low compliance with our policies and processes as it relates to oral oncolytics, which is really kind of how a lot of this change, which we'll present today, occurred. So At that time, really our focus was on a number of buckets from a policy and process perspective. And this kind of aligns with what ASCO, ONS, COPI, which we'll talk about here shortly, a lot of the quality initiatives and best practices that a lot of our national groups put out is how they divide kind of their recommendations. But first was how we're consenting patients for chemotherapy. Secondly, how we're educating patients. So at that time, we had a lot of variation in the clinics, particularly in terms of who was doing the education and what types of materials were being presented to patients. Monitoring. So again, given these patients are taking these agents more in the home setting, we wanted to have a process where we had a specified points in which we were reaching out to patients to monitor for adverse effects as well as drug interactions. And then finally, documentation. So we were really struggling with kind of standardized approach to where we were documenting things, including some of the education, the monitoring, toxicity, et cetera, in the EMR, which was leading to confusion among staff. So really where we've kind of drawn from with a lot of these processes has been from, like I had kind of aforementioned ASCO and ONS, which ultimately flows into COPI, their quality initiative. So they've put every 3 to 4 years, they'll put a safety standards out, which was novel in 2013 because that was really the first time that those safety standards included specific recommendations for oral chemotherapy. Since then, we've also seen a couple of other iterations of these standards, and internally, we've really relied on these to kind of compare our internal processes against these to ensure that we are, again, most safely utilizing our oral oncolytic agents. So those standards ultimately flow into COPI, which is the Quality Oncology Practice Initiative, which is an ASCO product. So some centers, maybe centers you've worked at or been familiar with, do go through COPI certification. And that kind of is just another way to show that as a center, they're most or that they're practicing according to those safety standards. So for us as a center, we often use COPI as a kind of a benchmark for our practice, just to ensure that we're safely taking care of these patients. So that's kind of what we've done here at a number of points since these were released. So essentially just kind of a series of gap analyses regarding our practice against best practice. So essentially for the policies I'll now present, that's how these were developed. And align with kind of what's been recommended nationally. So I'm going to segue into the kind of the meat of what we do from a process perspective. And here kind of are the buckets. So I'll talk about a couple specific policies that I think it's important that you're familiar with as a chemotherapy prescriber at UW Health, including prescribing, dose modification, prospective order review, education, monitoring, and then ultimately treatment discontinuation. So the first policy to be familiar with is policy 6.1.1. This may have been referenced in another talk already. So this is our kind of all-encompassing policy regarding chemotherapy processes at UW Health. So this covers consent, ordering, verification, administration, documentation, as well as education. So I did want to, I can just pull that up quickly and just highlight a couple of aspects. So the policy reads kind of, in a number of buckets. I did want to just make you aware that within UW Health, because of some of the confusion about what would be considered chemotherapy versus not, we actually have an appendix to this policy, Appendix A, that we kind of perpetually maintain that does list medications described as chemotherapy at UW Health. So this is broken out by route of administration. So if you ever have a question, or clinics may have questions about does the policy apply to a particular agent, this would be the policy to go to. So for example, an agent like abiraterone, available orally, via hormonal mechanism is considered chemotherapy here, given it's kind of predominantly used for, or always used for oncology indications and some of the monitoring associated with it. So the components of this aforementioned 611 would apply. However, an agent such as tamoxifen, another hormonal agent may be used in the adjuvant setting in a breast cancer population, for example. That is not listed on this policy, so tamoxifen would not have the requirements, for consent and everything that this policy encompasses. So I think that's an important thing just to be aware of. And again, this Appendix A would be the source to see if an agent would apply. We do have some agents on this list, for example, say cyclophosphamide, methotrexate, which we of course know are used, very often in non-oncology populations. So for that purpose, this policy does kind of tease out chemotherapy when used for oncologic indications versus chemotherapy used for non-oncologic indications. So I think that's an important differentiation point. So for example, informed consent, is listed here that would be required for a patient who's going to be using chemotherapy for an oncologic indication. There also in here is, ordering some of the treatment plan information, verification. So kind of on the nurse and pharmacist end, at minimum, what types of processes do we have in place as it relates to verification? And then this is the section on non-oncologic indications where we kind of draw out that differentiation that, informed consent is not required. So those are just a few of the highlights, but this is an important policy. If you have questions regarding ordering and kind of what applies from a system perspective, to be familiar with. Additionally, I wanted to just point out that this policy does have another appendix, Appendix B, which is specific to oral chemotherapy. This is a briefer appendix, and a lot of what's in kind of the meat of the policy, of course, does apply, but just calls out a couple of specific nuances as it relates to oral chemotherapy. So, calling out that we should be ordering oral chemotherapy via our approved Beacon protocols. Our order verification process, which we'll touch on, education, and then some of the monitoring pieces. So that we felt this was put into place probably about 5 years ago, but we felt like it was just kind of important clarifications from a workflow perspective. So any questions from the group on any of that information? All right. Hearing none. So I'll just move it to the prescribing section. So we talked about and saw in that policy that informed consent is required when using a medication defined as chemotherapy in the oncologic setting. So that would follow our kind of standard consent process. In terms of our treatment plans, so we do have, again, it's standard that oral oncolytics are ordered out of our Epic Beacon prescribing suite, just how they would be ordered for IV chemotherapy, because many of these agents have just as many or sometimes more kind of monitoring and safety parameters that come with them. I did want to touch on our current state of this hybrid model for oral oncolytic prescribing. So currently we have kind of a mix of how reordering from a prescribing standpoint would occur within a treatment plan. So what we have is certain products that have, either, very high toxicity, or maybe have, say, an associated REMS program that don't allow refills on a medication. Those products need to be ordered every cycle out of the plan. So I can just show you, just for an example, I don't know that you'll be prescribing lenalidomide, but if you would see lenalidomide and, of course, its associated REMS program, we have the medication order in here, which will really default to no refills. And then if you would look at kind of subsequent cycles, you would see similarly, the medication is included in here with no refills. So really the purpose of this is that, we should be keeping up and ordering this medication every cycle out of the plan. We have a couple of other plans configured, like for example, imatinib, which once patients kind of demonstrate tolerance to an agent like this, we often add refills, and patients are seen, maybe not on a monthly basis. We'll have that medication in here kind of to start for the initial fill. However, for subsequent fills, what we have is essentially like a placeholder that would point the prescriber to the medication activity to actually refill the medication. So the reason that we do that is just because some clinics, again, based on the patient's kind of like tolerance, it's going to be variable in terms of, how often you're seeing patients for subsequent evaluation. So we should still keep this plan updated with the labs and kind of the monitoring that occurs. However, this kind of allows the prescriber a little bit more latitude in terms of adding refills and ultimately doing that reordering in a med activity, just like you would reorder kind of other medications. So that's a nuance that I think each clinic operates a little bit differently, and we're trying to see if a more standardized approach within plans would be more beneficial. However, to date, we've kind of used that hybrid approach just from a workflow perspective. So as prescribers, I wanted to just call that out. Also with prescribing, we do allow refills really for the majority of our oral oncolytic orders. Again, some of those notable exceptions include products such as product that would have, would have a REMS program associated with it that would not allow refills per that program. We've really tried to hardwire our refills into the plans as much as possible, or are doing that more. So, for example, in our like our gyn-onc population who maintains a number of PARP inhibitor plans, they have moved to kind of standardize how often they see patients as patients tolerate therapy. So they see patients on a monthly basis for the first 3 months, and then they space those visits out as patients tolerate the medication. So within those plans, the refills actually are kind of built in as recommended based on those clinic visits. So we're hoping to do that kind of, I think, more with our disease-oriented teams, just because from a prescriber perspective, I think it's a little bit easier to kind of track, how many refills a patient may need. So dose modification. So we do have a process that we follow with how dose modification is documented. So this is required by prescribers for all chemotherapy, including IV as well as oral. We do have a special note within the medical record with a standard format that you can see below, where prescribers should be entering this whenever there's a dose modification on a therapy. Really, the reason that this was put into place is kind of when I talked about some of those earlier misadventures, particularly with oral oncolytics, we were having trouble kind of having a centralized place where this documentation occurred. Particularly, say a patient maybe calls in with some sort of toxicity, and the prescriber may tell the patient to hold a therapy or reduce a dose. Sometimes that guidance may be outside of like an actual clinic visit. So this note, the standard note type, helps us track that a little better. Ultimately flows to our kind of synopsis reports, which all staff have access to. And then it's just easier to see kind of what the source of truth is for the patient's actual dosing. So if you do enter chemotherapy without this type of note entered, you're likely going to get a reminder from either a nurse or a pharmacist to put it in, just because we are pretty diligent about tracking these. And this is available in your navigator within your kind of prescribing suite. So you'll see it's called oncology, treatment modification. So that's a little bit about our dose mod documentation process. We do have a prospective order review process. So this is a process whereby pharmacists do a verification step for orders when they're signed within Epic. So if you as a prescriber would order a chemotherapy or reorder a chemotherapy out of the medication activity, or if a chemotherapy order would be released out of a plan, this would then route to a basically verification queue that a pharmacist could see. And then a pharmacist would do the same types of kind of checks that they would for an IV treatment in clinic. So this really has helped a lot in terms of safety. We've tracked data on this over the last 6 years and have kind of consistently seen about a 20% intervention rate, which kind of smatters across a number of different types of interventions. One would be kind of what the pharmacy would be that the patient could fill at. So based on the authorization, that's something that the pharmacist will check as well in this queue, just to make sure that it's routed appropriately so patients get it as timely as possible, as well as the monitoring labs, drug interactions, those types of things as well. So this is a hard stop, meaning that the drug is not transmitted from Epic to the destination pharmacy until the pharmacist does do this check, just from a safety perspective. So I think the takeaway for the prescribers is just if there is a question about this, obviously a pharmacist would reach out to you just to get any clarification needed from a safety perspective prior to moving forward with the order. Education, I kind of touched on this, but we do per policy require education prior to initiating a patient on oral chemotherapy. At this time, pharmacists do kind of, I'll say, own this within the clinic. Nurses more own the in-clinic teaches. We had that in place just because we felt like the pharmacist was best positioned to kind of go over adherence, as well as from an authorization standpoint, kind of help facilitate that. So really, I think the biggest takeaway here is, when you're working in clinics and with patients, if you could notify our team, that would just be really helpful. Really, as soon as you're thinking about this as a potential agent, just because we can be proactive then with meeting with patients and scheduling that education out. We do have a portal on UConnect where we house some of the information regarding the teaches. If you'd search oral chemotherapy, you can see that there's this portal. We have a link to our appendix that we aforementioned, as well as patient education handouts that we're using. So these are actually maintained by a third party of organizations. So ACCC, HOPA, which is the pharmacy group, ONS, the nurse group, and NCODA, which is the community oncology group, kind of partner to keep these up to date. So these have been vetted through the center and have felt these are kind of the best to be offering patients. So if you go into the library, you can actually search by agent. If you are looking for a particular agent, so if you're going to be doing, say, capmatinib, you could look that one up, and then there's going to be kind of an attestation, and then can link you right to the PDF. So these go over things you would expect: dosing, drug interactions, storage, and then the drug interactions are then listed: serious side effects, handling, pregnancy, and then some resources. So these are the templates that pharmacists use as well. But if you're looking to kind of print one out for a patient, you can go to that portal via the oral chemotherapy search in UConnect, and there's a link out to these handouts. There's also, LexiComp. We use those patient education sheets for some of the in-clinic therapies, so that's an option as well. And then we do have a diary. This is also linked off of that oral chemotherapy portal. So this is a tool that if you want, if patients ask for kind of something that they can be checking off their dosing against their symptoms, this is something that could be provided to patients. Pharmacists use this occasionally, as well as maybe some personalized calendars that we'll put together for patients. So, all right, so that was kind of the highlights of the education. I do want to talk briefly about monitoring. So we did talk about how, again, with the shift in using these agents, and how we have patients kind of more in the home setting, how we're kind of reaching out to patients. So this is from the guidance, but essentially it does recommend that each practice does have a policy or procedure as it relates to an initial assessment of patients' adherence. And those include kind of the aspects below. And then also we have a plan for ongoing assessments of both adherence as well as toxicity at each clinical encounter. So I guess what that has meant to us is that, from a pharmacy perspective, that we, have certain processes in place to help augment, your your clinic visits with patients, just so that we're, again, reaching out more often to see how things are going. So what that means to us at this time is really all patients that are started on oral oncolytic at UW Health are contacted about 7 to 10 days after their plan start by a pharmacist. We do this just to confirm that the patients receive the medication, that they're starting to take it appropriately per the dosing recommendations, screen for any early adverse effects. After that initial touch base, we then have kind of periodic touch bases based on the patient's risk factors. So if they would tell us that if they would display a high risk for non-adherence, or have toxicities that we would see, we have an algorithm that we follow, and that would kind of qualify them for more frequent touch bases. That kind of ongoing follow-up has been something that's been impacted for us with kind of the ongoing COVID situation and some of those operational pieces. So we do that as much as we can for the resources we have had to scale that back a little bit, but we have continued to be able to offer that kind of initial touch bases. For patients that are filling within our internal specialty pharmacy here at UW Health, those patients do get monthly refill reminders for their medications, and then talk to a pharmacist at minimum every 3 months as part of their kind of filling here as well. So that's kind of another step in terms of how we keep an eye on them. We do fill out a standardized note with an Epic, so we're not using a third-party software at this time. That note is documented within the EMR, and then we do share that with prescribers if there's something pertinent that is seen. If we would screen for a toxicity that we felt was urgent or emergent and needed immediate attention, pharmacists would be reaching out to ordering providers, as well as recommending patients are kind of put through the triage process to assess if patients, if there's an ED visit or something that needs to happen. So we would escalate that if necessary. I did talk about our documentation process. So we do have standardized notation that we put through. And again, these are just some of the buckets that we touch on, but these are all kind of recommended per COPE and best practices. And as I mentioned, we would send those to the authorizing provider. Just a couple of other topics just to briefly touch on before I segue into the specialty pieces. So at kind of all the processes we talked about today with the verification really rely on Epic and kind of the safety mechanisms that we're able to put in place as it relates to prescribing. Unfortunately, with paper ordering, we have less ability, to put that into place. So we've really tried to minimize that if possible. We recognize that I think really the majority of our paper ordering still occurs in the sense of patients that need medication assistance programs. So some of you may have been involved with that already, but essentially for patients that may have high copays or financial hardships, we have a team that helps kind of investigate medication assistance programs, and often those applications are paper faxes over to the company, which does include an order for those products. So I think that's where, again, just involving us being pharmacy kind of in the clinic so that we're aware that patients are investigating these is just really helpful. We just want to ensure that patients still have that medication on their medication list, that it goes through a verification process, that we can enroll them for the monitoring like I talked about, because without the trigger of kind of the electronic order, that can get lost and then will impede, our ability to safely order that. So just something to be aware of. And then secondly, I touched on the REMS programs. I think, from a fellow APP standpoint, you may or may not have, sign up for these, but we do have a number of products in the center that we do manage where our prescribers will have to go through additional certifications through the manufacturers to be able to order those types of products. We do have guidance that is included within kind of our order sets for that. Happy to kind of help facilitate if you expect to be going through any of those processes. So Any other questions, comments on the oral oncolytic pieces before I transition to specialty? I'm guessing we'll wrap up a little early. All right, hearing none. The last 5 or 10 minutes here, I want to just cover some aspects regarding our specialty program and prior auth, just because this is kind of very involved with our oral oncolytic workflows. So just so everyone's aware, as a system right now, we preferentially dispense specialty medications at our pharmacy services building, or it's referred to the PSB. This is located out at 3185 Deming Way in Middleton, so about 15-20 minute drive from University Hospital. The reason we do that is there are a number of specialty requirements for these high cost medications that need to be completed kind of to access them as a system, which requires a pretty large footprint just from a kind of operational perspective in terms of how we fill the medications, how we mail them, if there's a a refrigerated item, how we kind of ensure that that medication is kept cold on while getting it to the patient. So kind of all of those pieces is really the reason why we've had to preferentially dispense at the PSB. So what that means for our patients is that really mail order or delivery is preferred. This is a free service that center offers. And when ordering from that facility, we generally can do a next day courier shipment for patients that are in the immediate area. There may be some variations in terms of weekend delivery. So say we get a new order on a Friday, particularly if it's later in the day, if that's something we can offer. Or for patients that live in kind of our outlying rural areas, that may take a little bit longer. And we are, of course, reliant on USPS and some of the actual couriers that do these things. But that's just kind of more kind of on what to expect for patients. We do allow patients to pick up at that facility. As you can see from the building shot, it definitely is more of a warehouse location. The front door is located there. It wasn't really designed to be a kind of outward-facing pharmacy. However, if there is kind of an urgent need, patients could do that. We do ask for at least a couple of hours to turn that around, and then there's a process where patients kind of call from their car, and then we bring it out to them. That process has been in place really just since COVID. So that is available, particularly if patients live kind of in the immediate area. We still do all of the aforementioned monitoring pieces. So like I mentioned, the teach, all of those outreach things are done for the patients. Patients do receive kind of refill reminder calls. So that was historically done on a phone-based platform, however, is now moving to a text-based platform for patients that are interested. And that will just, send them a reminder 7 to 10 days ahead of time to order a refill if appropriate. As we're aware with many of our agents, particularly as we're just starting therapies, there may be a required clinic visit or assessment that needs to occur by a provider prior to kind of wanting to authorize that next fill. So that's just kind of something to keep in mind with kind of how we're timing these and kind of if we're putting refills on them based off of the complexities of the agent. We do have a prior authorization team that also is out at that facility. And this is for kind of UW Health as a whole. So they are kind of broken down into a number of pods. So these are primarily pharmacy technician folk, but we do have coordinators one group who's focused kind of on our medical benefit, which is our in-clinic therapies. Another group that's focused on our pharmacy benefit, which is our take-home therapies. And then we have our MAP program, which is medication assistance program. And those are the group of individuals that you could refer patients to if they have, a high copay and we want kind of additional investigation into, maybe a free drug for them through kind of a manufacturer program. So really just how our workflow, works is after you would, determine the need for a patient to start on therapy, we would submit that authorization to the payer. In the clinic setting, we are or any setting. Currently, we're submitting telephone encounter requests using a .onc PA dot phrase to the team to get that kicked off. Nursing and pharmacy would be happy to help you with that. We do have some providers that do submit their own PA requests as well, if that's something that you're interested in. But that's how that gets kicked off, and then our team submits that to the payer, and then we can, of course, await the verdict. In terms of kind of what to expect from a turnaround, we have it definitely varies by payer, and it varies by the request. So if you're requesting an FDA labeled product or NCCN approved, there may be a higher likelihood that that's a quicker turnaround. However, even for those types of products, some payers may have up to a 14 or 30-day review period. So we of course work with you to hopefully push those payers to get us the answer as soon as possible, particularly if it's medical urgent. But that can be an issue. I did want to point out that chemotherapy counsel and kind of the processes that go along with that in terms of patient-specific review is a separate process from insurance review. So say you're going to use an agent for an off-label indication where there is no standard of care or core regimen. You would still need to submit that through chemotherapy counsel for kind of a clinical and safety review. The council does not guarantee that then that would impact insurance review. That's a separate process. So at times, if we need to go through an appeal process or something, we can use the chemo council approval as part of our kind of ammunition of backing up that request, but it's not always the case. Some providers have elected to pursue the insurance review first, just because then if the insurance does not cover it, then they would kind of hold on doing the chemotherapy counsel part. So that kind of would be, I'd say, up to you. I kind of talked about how long, but again, it can be based on the insurance, so it really can vary. But I think particularly with these oral medications, and especially for, say, our Medicare patients who may have variations in their supplement coverage, which may result in a high out-of-pocket, it can take quite a bit of time. So this is kind of my last slide on just some of the options for underinsured or uninsured patients. Again, our goal here is really to provide these to our patients as much as possible and not let this be a barrier. However, there are kind of nuances with each patient case, which would qualify or not qualify patients for these options. So we do, again, have manufacturer and free drug programs as one option. Often those programs are going to have some sort of financial qualifier for if patients are able to access those. We have copay assistance programs, so most manufacturers do offer those. Many of the manufacturer programs are going to be limited to patients with commercial insurances, and government-funded insurances will be disqualified for those types of programs, which can be a challenge for our Medicare and Medicaid populations. We do have foundations and grants that are specific to oncology, so the Leukemia Lymphoma Society maintains one. There's a number of chronic disease funds. We'll explore those for patients. Those can be variable, so depending on how the fund's doing, we may look in a month at a patient, and then we might look, and there might be nothing. We might look in the next month, and there could be some funds available. So those are a bit hit and miss, but we, will absolutely explore those to try to help mitigate cost issues for patients. And then kind of finally, we do have some kind of community care and other funds as well for our indigent patients. So I guess the last point on this slide was we have a repository program. So what that is patients can actually donate us unused medication. We do have to verify that the medication is essentially sealed and not tampered with. But pharmacists can or pharmacies can take that through a program within the state, and then we can actually use that for other patients, maybe who have some financial issues. So we do that a lot when we're trying to maybe bridge a gap with an insurer, or for products like growth factor, where patients may be on it for maybe a limited amount of time. Those are good options, but a pharmacist would obviously be able to help you explore if that's an option. So so that was kind of my piece on specialty. I think, again, just the takeaways here from an oral oncolytic standpoint, I think just to be familiar with our 6.1.1 policy and everything that goes into that from consent verification, monitoring, and documentation. And then on the specialty PA end, just our team that's going to do all the medication PAs for your patients, submitting us those telephone encounters so we can get that process going. Obviously, going to be some variations based off of the payer in terms of timeliness for how those are reviewed, but we will, of course, assist for in helping trying to expedite that, as well as exploring assistance if patients need it. So I'd be happy to answer any questions from anyone on the call.